Clinical Guidelines for Post-DVT Varicose Vein Treatment by Dr. Sina Rafat. Varicose veins in the post-thrombotic limb function as active mechanical drivers of post-thrombotic syndrome, perpetuating a cycle of chronic pain, swelling, and tissue damage. Severe ambulatory venous hypertension emerges when deep venous obstruction and superficial reflux compound one another. When the deep interior channel is blocked by pale, fibrous material, blood is forced into the parallel superficial channel, causing it to dilate and twist. To manage this circuit, we utilize a four-part framework: clinical indications, hemodynamic triage, the multimodal sequence, and pharmacological guardrails. Success depends on identifying the precise physiological threshold where a superficial vein stops acting as a vital collateral lifeline and begins functioning as a pathological source of hypertension. We categorize indications by their clinical urgency, starting with obligatory scenarios that mandate immediate treatment: acute hemorrhage from a varicose vein and active CEAP-C6 venous ulcers. This chart from the EVRA trial shows that early superficial endovenous ablation, performed within 2 weeks of presentation, significantly accelerates healing, reaching a median of 56 days compared to 82 days for deferred treatment. With a hazard ratio of 1.38, early intervention fundamentally increases the total amount of ulcer-free time for the patient. We then move to strongly recommended indications, beginning with healed C5 venous ulcers, where persistent reflux remains. The ESCAR study demonstrated that treating the superficial reflux source in these patients reduced ulcer recurrence from 56% to 31% over a 4-year period. Progressive skin changes classified as CEAP, C4A, and C4B, including lipodermatosclerosis and atrophy blanche, serve as critical markers to intervene before an ulcer forms. Furthermore, recurrent superficial thrombophlebitis requires definitive reflux treatment to interrupt the inflammatory cycle and prevent potential DVT extension. To grade the severity of symptoms, we utilize the Viltalta score. A score of 10 or greater indicates moderate to severe post-thrombotic syndrome. The C-TRACT trial demonstrated that for patients with Viltalta scores in this range, iliac stenting significantly reduces the venous clinical severity score compared to medical management alone. In summary, the urgency of treatment scales with the stage of disease. Target acute hemorrhage and C6 ulcers immediately, while aggressively managing C4 and C5 stages to prevent further deterioration. Safety begins with timing. We must wait 3 to 6 months following the acute DVT event to allow for maximal deep vein recanalization before performing any ablation. The most critical step is using duplex ultrasound to determine if the great saphenous vein is a collateral pathway or a source of reflux. As shown in Panel A, if the GSV shows predominantly antegrade or upward flow, it is acting as a critical collateral bypass for a deep obstruction. In this scenario, ablation is contraindicated and potentially catastrophic for the limb. Conversely, Panel B shows retrograde flow greater than 500 milliseconds upon augmentation. This confirms the vein is a source of hypertension rather than a bypass, making it appropriate for ablation. We must also account for the velocity of the deep venous reflux. If the maximal reflux velocity in the popliteal or femoral veins exceeds 10 centimeters per second, the patient is likely to experience persistent symptoms even after the superficial system is treated. The most favorable hemodynamic profile for GSV ablation is a prior below-knee DVT with fair recanalization, a normal small saphenous vein, and patent deep veins above the knee. Because the common femoral and popliteal veins are patent, the GSV is clearly not the primary outflow tract, ensuring the ablation will not compromise venous return. However, clinicians must be aware that the rate of endovenous heat-induced thrombosis is higher in this population, 6% compared to 1% in primary cases, requiring mandatory duplex surveillance within 48 to 72 hours. Ablation is only safe when the flow is definitively retrograde, reflux velocity thresholds are respected, and central outflow is patent. For severe PTS, we follow an inside-out hierarchy. Central outflow obstruction must be detected and eliminated before addressing peripheral reflux. standard duplex is often unreliable for the pelvic veins. If iliac obstruction is suspected, the clinician must utilize CT, MR venography, or intravascular ultrasound to visualize the obstruction. Step 2 is proximal intervention. Endovascular iliofemoral stenting physically displaces fibrous wall changes, restoring a wide central channel for venous return. Only once this central outflow is secured do we move to peripheral interventions. If the main saphenous trunk is functioning as a collateral and cannot be ablated, we can still target the specific incompetent perforators that are feeding the ulcer bed. Similarly, ultrasound-guided foam sclerotherapy allows for the treatment of symptomatic varicose tributaries without the need for truncal ablation. These interventions must be built upon a foundation of aggressive conservative management. This includes multi-component compression systems at 30 to 40 millimeters of mercury, supplemented by intermittent pneumatic compression for patients with refractory edema. The operational sequence is absolute. Stent the central iliac obstruction first, selectively treat pathological peripheral branches second, and maintain continuous high-grade compression throughout. Pharmacological management is complicated by the fact that nearly all post-DVT patients are already on long-term anticoagulation. The most significant pharmacological threat in this population is the use of nonsteroidal anti-inflammatory drugs. Co-administering NSAIDs that anticoagulants results in a hazard ratio of 2.37 for major bleeding and does nothing to prevent further VTE events. We must also exercise caution with alternative supplements, particularly horse chestnut seed extract. This extract contains esculin, a hydroxycoumarin derivative that can potentiate the effects of anticoagulants and trigger life-threatening hemorrhage. If using calcium dobasalate, strict hematologic monitoring is required. This drug carries a rare but severe risk of agranulocytosis, requiring a baseline and routine complete blood count for any patient on the therapy. For beneficial adjuncts, pentoxifylline at 400 mg 3 times daily has the strongest evidence for accelerating the healing of open venous ulcers. Venoactive drugs like solidexide or MPFF are also appropriate for short-term symptom relief, provided they are used as part of a comprehensive plan. The pharmacological rule for the post-thrombotic limb is clear: avoid NSAIDs and coumarin derivatives, and utilize verified adjuncts like pentoxifylline to drive wound healing. Treating post-DVT varicose veins requires precise hemodynamic mapping to recalibrate the flow of a damaged high-pressure system. The clinician must always distinguish between a pathological refluxing vein and a critical life-saving collateral bypass before attempting ablation. Always respect the mechanical sequence. Resolve central iliac obstructions before targeting the peripheral reflux. Combined with aggressive wound care and the strict avoidance of bleeding potentiating drugs, these principles form the standard for modern post-thrombotic care. Thank you for your time and for your continued commitment to advancing vascular excellence for patients with complex post-thrombotic syndrome.